I'm Emily Beauregard. I'm the chair of the Consumer TAC, and I'm also the director of Kentucky Voices for Health. And I'm very excited to have two new members joining our TAC today, and wanted to start by welcoming our new members and doing some brief introductions of our Consumer TAC members. So today we have Christine Jackson, who has been appointed by AARP Kentucky, and Rosalinda Stafford, who has been appointed by the Family Resource Youth Services Coalition of Kentucky. And I want to welcome you both. I thought maybe we could just do a brief introduction of what brought you to the Consumer TAC meeting. And Miranda, if you can introduce yourself as well so that they know who you are. So we'll start with Miranda and then go to Christine and Rosalinda. And one of the rules that we have for our TAC is that in order for us to be participating in the meeting and voting, we need to have our cameras on.
So welcome, Christine and Rose. I'm Miranda Brown. I work with Kentucky Equal Justice Center, and I'm a connector, so I help people sign up for Medicaid, and I am a member of the TAC.
Christine, would you like to introduce yourself?
Sure. So my husband and I have lived in Kentucky now for the past 8 years. We moved from California, and I have been volunteering with AARP as a lead volunteer now for about, I think, 5 or 6 years. And they had me do a lot of various things throughout the city of Lexington. And I've enjoyed it. I've enjoyed the team that we have. I think we've had about 30 people. And so that's been good to keep me busy. In California, I had my own small business for 18 years with employees, and I've had exposure to the whole healthcare being, having to provide that for employees in the past. But here in Kentucky, my husband worked for Lexmark for a couple of years, and then he's been doing contract work. So we've had our challenges with healthcare coverage. And unbeknownst to me, when AARP asked me about this position in the beginning in April, they actually didn't know that we dealt with Medicaid last year because of unemployment that he went through with COVID, and then also us not able to get unemployment. And so we ended up getting on Medicaid. So Emily and I just talked earlier because we have another situation. When he does contract work, health coverage comes and goes, and it's very stressful. So it's interesting that I'm actually a client right now, and I can give you firsthand experience. I just had my first experience with a connector last week. And so reading some of your notes from June, I'm like, oh, that's what that means, because there's a lot that you don't know. And I'm going to get educated. So I'm glad to be on the board. And I'm definitely one for advocacy for health as much as we can keep citizens healthy. And so this is such a good matchup. I didn't even imagine it would work out this way, but it did. So happy to be here.
Yeah, absolutely.
And Emily, Patsy's on her way coming in now too. So you've got
Oh, fantastic. Thanks. We'll just give it a minute so that she can hear from Rosalinda. Rosalinda, do you want to be called Rosie? I saw that in your.
Yeah, that's fine.
Okay, all right.
I can be called whatever. It doesn't matter to me. You want me to go ahead or wait till she gets on?
Charlie, is Patty in?
Yes, she should be.
Okay, great. Yeah, why don't we go ahead, Rosie?
Okay, my name is Rosie Stafford. I'm the coordinator of the South Ashland Family Resource Center. I've been a coordinator for 11 years. And I think this is going to be a great opportunity for me to get a lot of information that we could forward on to our families. There's family resource centers in every school district in Kentucky now. And a lot of the families that we work with will find a lot of this information very useful, I'm hoping. So. And I have a daycare in my building, so if my camera goes off, it's because I got children everywhere. So just ignore me on that.
Good to know. Thank you. Really happy to have both of you here on our TAC. And I think you're going to bring a lot of valuable information and questions and other things to contribute, and hope that we can address a lot of the issues that you're experiencing or seeing in your communities as well. Patty, if you are on and if you can hear me, we're doing introductions right now.
I can hear you. Thank you very much. Sorry, I'm running a little bit late. Good to see everybody.
No problem.
Yeah. I'm Patty Dempsey, and I'm representing the ARC of Kentucky, statewide advocacy organization.
And so we have a couple of other members. Arthur Campbell is a member who may join us later. And we are waiting for the Kentucky Association of Community Health Workers to appoint a member. So that brings us, I think, to our full 7 members of this consumer TAC. And we wanted to expand the TAC to have more perspectives, have more voices, and really glad that you all could join us today. We do have a quorum. In order for us to meet, we don't need a quorum, but to make recommendations and vote on them, we do need a quorum. So it's good to have as many members joining us for these meetings as possible. I mentioned that one of our rules is, in order to vote, we need to have our cameras on and be seen and heard. We also have these meetings every other month, and in the months in between, the full MAC, Medicaid Advisory Committee, which is technically called the, I think, Advisory Committee for Medical Assistance, but we all call it the MAC, meets. And that's not a meeting that you're required to attend by any means, but you're always invited if you have the time. And just recently, Medicaid, the Department for Medicaid Services, the commissioner, Lisa Lee, agreed to share recordings of the MAC and TAC meetings on YouTube. So if you do miss a meeting, or if you just want to go back to remember something that maybe you kind of missed or wanted to refresh, that should be available to us now, which is fantastic. Charlie, is there anything else that you want to cover for new members before we move on?
No, I think you've about covered it. Other than just to let everybody know that your meetings are subject to open records and the open meeting laws. So we try to refrain from bringing specific individual member issues up because of HIPAA. So if you have something like that, we may ask you for examples. If there's some kind of a situation happening, we may ask for examples. But in those cases, please email those examples to me, and then I can get them out to the correct people that asked for them. So we just don't want to bring that up. Now, if the member on Arthur sometimes brings up discussions, if it's your own, that's fine. As long as you're aware that it's a matter of public record. So just be careful in that regard.
And Charlie staffs these meetings for the Department for Medicaid Services. We appreciate all the work she does.
And
so,
Emily, if you may want just to have, because you do have some new members, DMS staff, if you all could possibly introduce yourselves, turn your video on so the new members can see who they may be dealing with at Medicaid.
That's a great idea. Thank you, Charlie.
Deputy Commissioner, if you would like to go. I think you're back on.
Yes, thank you, Charlie. That is a great idea. Hi, welcome to the new members. My name is Veronica Cecil, and I am the Senior Deputy Commissioner for Medicaid. We look forward to working with you. I will turn it to Angie.
Hello, I am Angie Parker. I'm the Director of Program Quality and Outcomes. Basically oversight of the managed care contracts for the most part, and a few other little things. I'll turn it over to Justin, our newest.
Hello, my
member.
name is Justin Derringer. I'm the Assistant Director in the Division of Policy and Operations. Today is my second day, so if I don't know something, I will get back with you. Thank you.
Pam, you want to go next?
Oh, yeah, okay. Pam or Leslie?
Sorry, I'm talking to you.
I'm sorry,
I am Pam Smith, the Division Director at Community Alternatives. So I oversee the 1915C home and community-based waivers.
And
This is Leslie Hoffman. I'm the Chief Behavioral Health Officer, and
Leslie, you cut out.
I'm the Chief Behavioral Health Officer and assist on the waiver side with Pam.
And I think that's all of them, besides myself, and you've kind of told what I do as the liaison for the tax and work in the commissioner's office. Guess I should have started a video so y'all can see also. So you can go ahead now.
All right, thank you, Charlie, and thanks to everyone from the Department for Medicaid Services for your introductions. One thing I was going to say is I'm going to try to do my best to not use acronyms or talk about things that, you know, the general public doesn't usually know or, you know, have much knowledge of. So I would also ask that, you know, for our Medicaid folks, if you can just give a little background or make sure to kind of spell out any of the acronyms that we often use. I think that would be helpful for at least the next few meetings. And to our new members, well, really all of our members, if you ever have a question, want some clarification or some background, please just let us know. Oh, great, Arthur's getting on. So we'll have Arthur do an introduction quickly, and then we'll move on to the minutes. And hopefully everyone received a copy of the minutes from Charlie in advance. Charlie, do you know if Arthur is in from the waiting room?
Here he comes just now.
Okay, great.
Looks like you might already be in.
Hi, Arthur. You can hear me.
Looking all dapper.
Hi, Arthur. We are doing introductions right now. So you made it just in time for that. And then we're going to go on to the minutes. If you don't mind just unmuting and introducing yourself. We have two new members on today, Christine Jackson and Rosie Stafford.
You've been trying to find a Zoom to get on.
Yeah.
1:30.
Arthur, your assistant who's interpreting is kind of hard to hear. If she could maybe move closer to the computer or microphone.
He said he's been trying to get on the Zoom ever since 1:30.
Oh, gotcha. Thank you very much. I could hear that.
Sorry.
He is sorry. That he didn't make it on time.
Oh, no, that's quite all right. I know Zoom can sometimes be hard to get onto. Arthur, would you mind just doing a quick introduction of yourself and who you represent on the TAC?
I am Arthur Campbell Jr. I represent EDA, TNA, on the chat. See. T, I see. T, A.
TAC?
Yeah.
Yeah, thank you. Arthur represents the protection and advocacy on our TAC. And people who have Medicaid and have disabilities and need good access to care. So really glad that we have all of our current members on today. We're going to go ahead and look at the June minutes, and I'll take a motion to approve those minutes unless there are any changes that we need to make.
I motion to approve the June minutes.
Thanks, Miranda. Can I get a second?
I second.
Thank you, Patty. All in favor, say aye.
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 Any opposed? All right, motion carries. And we'll move on to our next item on the agenda, Medicaid enrollment. This is something that we try to track regularly through the consumer TAC. We're always interested in knowing how many Kentuckians are enrolled in Medicaid at any given time and how that enrollment process is working. So our first question is how many Kentuckians are currently covered under traditional Medicaid, which is Medicaid, as it was defined before we expanded through the Affordable Care Act in 2014. And so that's traditionally low-income families, pregnant women, children, and some people with disabilities, and then expanded Medicaid for adults with, incomes that go up to 138% of the federal poverty level. And then how many Kentuckians are covered under presumptive eligibility, which is a type of temporary Medicaid that people typically are covered through for just a limited amount of time before they can enroll in full Medicaid. So I'm guessing, Veronica, are you going to be answering these questions?
Yes, I am.
And if ever you want to expand on that or correct me, please do.
No, I thought you did a fabulous job of explaining those terms. Again, Veronica Cecil with Medicaid. Our enrollment, total enrollment as of Monday this week is 1,570,546. So close to 1 point, still we're toggling around that 1.5 to 1.6 million lives. And for presumptive eligibility, again, as of Monday, we have 7,962 individuals enrolled in that category. And also maybe just a really quick, what is temporary? For right now, under the public health emergency, temporary presumptive eligibility coverage, you can have 2 PE periods per calendar year. And each of those presumptive eligibility periods is the month of enrollment plus 1 month. So a total of 2 months. So that means that someone right now under the public health emergency that needs coverage, and this is primarily focused on individuals who aren't covered or who do not have hospital, pharmacy, or physician coverage. They can have a total of 4 months of coverage during the calendar year.
Yeah, thank you. That's really helpful. And Veronica and I exchanged some emails yesterday about PE coverage and individuals whose coverage ended at the end of June, but it sounds like there are some Kentuckians who maybe inadvertently got notices or cards for coverage starting on July 1st. And we're just wondering what kind of outreach is being done to people whose PE coverage has ended, how, are individuals, getting that information, and what's being done for the ones who maybe got some conflicting notices.
Sure, thanks, Emily, for asking those questions. So a member whose coverage is about to end gets a notice about 30 days before that happens. Currently, our presumptive eligibility notice includes language that encourages the member to file a full Medicaid application. That's what we primarily have been trying, working with our greatest sisters out there as well, trying to get members to file that full application so we can make a determination as to the possibility that they can continue in Medicaid. They're also being encouraged to get on the exchange, which now, unfortunately, open enrollment ended on the 15th, but the next open enrollment period will be coming up soon. And, we again encourage folks to access the different options that are on the federal exchange to get coverage that way. United Healthcare, and not to put them on the spot, I think they have representatives on, but they have really been doing a great deal of outreach. I know they've been calling folks and sending other notices and trying to communicate with their membership, because the majority, or I should say pretty much all of presumptive eligibility membership is with United. So I know they've been doing a lot of work around trying to, again, encourage those members to file their oh, yes, thank you, Emily. Yes, it is qualifying event. Thank you. To notify them, that it's coming to an end. Regrettably, I think what happens is that the member will walk in to get services. And I will tell you that with a great number of individuals dropping off on June 30th, July 1, when we went to the single pharmacy benefit manager, we had lots of folks coming in who no longer had coverage. And it is absolutely not what we want to happen. What they're told is to reach out and see what's going on. And that's our opportunity, again, to talk with them and encourage them to file a full application or to go to the federal exchange. So I don't know if someone from United wants the opportunities to talk about some of the things that they're doing. I'll pause for a moment to see.
Hi, Veronica. This is Whitney Allen with United
Whitney.
Healthcare. Hi.
Yes.
I can speak for just a moment on some of the things that we've done. So we are also sending out a notice to all of our members that are ending coverage. So for example, the ones that are presumptive eligibility members that will be terming on 8/31, end of this month, those letters went out this week. And Emily, I can share a copy of those notices if you want to distribute or for folks to have a copy of that, but it's just notifying them that they did have presumptive eligibility coverage, what that was, and encouraging them to complete a full Medicaid application before their coverage ends, and then resources for how to do so, going to connect or how to get in touch with an in-person connector or calling DCBS. And then we also have a team that is calling all of our presumptive eligible members that are having coverage being termed during that current month. And they are calling members. It's a live member advocate that's making those calls, and we try to make at least 2 attempts prior to their coverage ending for the end of that month, and then leaving messages as well. And it again is just notifying them that coverage is ending and ways to complete that full application. They can do a warm transfer right then to connect to do the application, or send them resources if they want to touch base with an in-person connector or apply online as well.
Thank you, Whitney. So I had kind of alluded to some issues that we'd heard of about people who did not realize that their coverage was ending or received a card for coverage, starting July 1st. And I'm wondering if there's anything that's being done to specifically kind of correct that information if they received the notice about the single pharmacy benefit manager along with the new card when their coverage was ending on June 30th.
Yeah, we had been hearing that as well. I think there's a lot of confusion when we were required to send out those new cards because of the PBM switch to mid-impact. So we did place a notice on the website letting people know of that switch, why they received a card. And we had been outreaching to connectors as well letting people know. I think there was a lot of confusion with the PBM switch and how close it was to so many members that were terming end of July.
Yeah. Does anyone have any questions, either for Whitney or for Veronica about that?
Not about that, but about presumptive eligibility, if now's a good time to ask.
Yeah, I think this is a good time.
I've been hearing from a lot of people who enrolled in presumptive eligibility over the last year who now lost it or are about to. And turns out that during that time period, the moment when they got enrolled in PE was when they were at a provider at a hospital, and that's what the provider enrolled them in, when really they were having an emergency and could have been enrolled in emergency time limited Medicaid, and maybe would still have Medicaid now. And so I've been signing some of those people up who are still within the time limits to sign up for emergency time limited Medicaid. And so I'm wondering, it just seems like maybe now would be a good time to remind providers that that is something still available that they can sign patients up for, that may last longer than the presumptive eligibility option for some of those patients.
Miranda, I'll take that back and talk with Lee guys about, what we might be able to do around that.
So I have a clarifying question there. I don't think that I knew that if you had used your 2 PE periods for, presumptive eligibility, that you would not be able to enroll in emergency time limited Medicaid within the same year. Is that what you're saying, Miranda?
No, so they can sign up, but usually my understanding is you have to sign up for emergency time limited Medicaid within 90 days of the emergency.
I see.
So I was saying if the time has already passed, then my understanding is that they can't get the emergency Medicaid. So some of the people I've talked to had COVID and have ongoing long COVID symptoms and problems and need ongoing care, and really could have been enrolled in emergency Medicaid from the beginning.
And signing up for presumptive eligibility doesn't satisfy that requirement of having signed up within the first 90 days of the onset of the emergency.
That is something I'm wondering about.
Yeah, and again, it's a very difficult thing, especially we expanded presumptive eligibility for the purpose of covering people related to COVID. And so it's going to be a very difficult thing to message, but again, I'll take it back to Lee and we'll see how we can better articulate the differences. Providers are just trying to get people covered, and I think it's difficult for them to discern which is the better one to help them apply for. But let me see what we can do.
I think Emily made a good point in that I guess a good question to ask, which is if they signed up for PE and that PE ended and they need ongoing care, could that PE enrollment satisfy them having applied for coverage during the 90 days?
That's the other thing I can take back is ask if we can, move the coverage over to emergency Medicaid.
Okay, because that could probably, I haven't, so far I've been able to help the people I've helped in time, but that I'm sure that will help many others.
Sure.
Thank you.
Yeah, I'm glad you brought that up. Thanks, Miranda. Anything else related to enrollment before we go on? Our next question is,
This is Christine. At being on the client side of it, I was wondering, is there any way that a diagram or a grid of some kind can be made that's very user friendly, because there's so much variation going on, and I know it's ongoing changing as we deal with the variant and all of that, but it would help a little bit to see something visual in a grid-like form or a map of something, because it's like I don't know if there's anything like that available.
Are you thinking of the different types of Medicaid?
Well, just now in this last, 15 minutes, there
Mhm.
the variants, right? There's all
Right, traditional Medicaid, expanded Medicaid, presumptive
Or-
eligibility.
or even
emergency.
somebody who has an emergency. And, so there seems to be there's so many ways that you can go with it. And I think you in the business, you guys know it a lot, but those who are just either getting it or exposed to it, that's what makes it confusing, because there's no, visual always helps to see where do I fit in this myriad.
Yeah, absolutely. And to be honest, it's confusing for those of us who work in it every day sometimes. So I don't know, Veronica, does Medicaid have some sort of grid that we could share with our TAC members?
Let me take that back and see.
That would be helpful, because there are different, kind of eligibility rules for these different types of Medicaid, and some have different benefits. The other major program is the 1915 Sea Waivers. And for the most part, the consumers, the people who enroll in Medicaid, it's like you don't necessarily need to know what type of Medicaid you're applying for. As long as you're eligible, we don't want to confuse, overly complicate it.
And that is the difficulty. It is very complicated, good or bad, right or wrong. It's very complicated. And that's why on Connect, we've just tried to make it very simple that, you can go through and see if you're eligible by answering some questions, because it really, it's household income. And there are just so many, impacts to whether or not you're eligible. We could absolutely provide sort of the different boxes, I think. What's going to be difficult is trying to put in every box what all of the eligibility requirements are, because they are, again, very case specific, based on somebody's income and how many are in the household. And let me tell you, even if we get into dual eligibles, which are people that have both Medicaid and Medicare, it's bad. It's just bad. It's really, really difficult to follow. And so let me see. We'll take it back. Let me see what we can do. We are always open to trying to make things easier to understand and user friendly. So certainly, I appreciate the ask.
Yeah, thank you. And I'm not thinking of, I think the way Connect handles coverage is beautiful. We want people to go in one door. We want people to find out what they're eligible for without having to know all the nuances of every program. But I think in this case, just for education, not necessarily something we would, share with every Medicaid member, but something that could be available when people ask. I think it would be a helpful document, and maybe a little more high level than every single type eligibility requirement, but could kind of describe the differences. So our next question here is, what plans are in place for recertifying Medicaid members when the pandemic maintenance of effort provision ends? And this is something that Christine and I were talking about before the call. So this maintenance of effort is a federal requirement. States had the option of getting a higher federal match, which means more federal funding for our Medicaid program, if we agreed to keep people covered during the public health state of emergency that's been created by this pandemic. And so for now, people only lose Medicaid coverage if they're fully enrolled for three reasons. One, moving out of state. The other would be if someone passed away. And then the third would be if you requested it. So we know that at some point, the public health state of emergency is going to end. It's a federal state of emergency. And then Kentucky will have to make sure that everyone is up to date with their recertifications and so on.
Yes, and that's a good question. We are asking it as well. CMS just issued updated guidance this week. So we're reviewing that and seeing, obviously we'll come up with a plan, but it's been it's changing frequently, and we don't know when the PHE will end. What we do know is, fortunately, CMS has heard the state's concerns about how quickly we could move to recertification, and understanding, the resources that are needed to do that. And so, we're reviewing that guidance, and we'll be developing a plan to put into place once we get word that the PHE will be ending. CMS did commit to give states 60 days notice before the end of the PHE. So then we at least know that, we will spring our plan into place. We'll have a little notice to do that. So we were grateful for CMS to at least give us that.
That is good to know. I briefly looked over the guidance, and one thing that stood out, it looks like there will be a year for, the recertification piece, but for something like the emergency SPA, the state plan amendment, in which Kentucky asked the federal government if we could, one, do more PE enrollment through the state, the eligibility process through the state, and then have those 2 PE periods. That ends on the day of the public health emergency ending. So are you working on making that permanent through a regular state plan amendment?
So the 2 PE periods will go away. That is just something that they can waive under the public health emergency. So even if we requested state plan approval for that, we wouldn't get it. But we are interested and are exploring filing a state plan amendment to keep the agency as someone who can determine presumptive eligibility, because we do think that has been beneficial to coverage and access, and so we're definitely interested in doing that. But so we have a list of things that we know we can ask for CMS state plan approval. The problem is that CMS won't entertain any of them until they know the PHE is ending. Because what they say is we currently have authority to do it, and they're not going to give us authority through the state plan. So we're in this difficult position of trying to be prepared, but concerned about a gap once it ends and having to make those changes.
Okay, well, that's good to know. So when you get that 60 days of notice, you'll basically have 60 days to submit a state plan amendment.
That's our plan, and that's when we think CMS will allow states to file those.
Okay, thank you. And just to go on record, I also think that having the state as an agency to do PE determination is absolutely helpful for Kentuckians, and I would hate to see it go away. Any other upcoming changes that we should be aware of?
The only thing I want to announce is our open enrollment is scheduled for October 15th through December 1st. And the member mailings will go out around the second week of September. We'll start going out around the second week of September. We do plan on having the side-by-side again to make it easy for members to understand what the value-added benefits are for each of the managed care organizations.
Great. Thanks. Anybody have any other questions, whether it's about Medicaid open enrollment or anything else we just discussed? Okay. Well, that was a lot of helpful information. And the next item on our agenda is 1915 Sea Waivers. We weren't able to cover this as much at our last meeting. We've continued to ask about the status of the EVV implementation. And Pam, if you don't mind just giving a very brief description of what that is.
What it is, yes. So EVV stands for Electronic Visit Verification. And in the 21st Century Cures Act, it is required that states use EVV for personal care services and home health care services. Personal care services were required to be implemented by 2021 for states that were given an extension, which Kentucky was. Home health is required to be implemented by January 1st of 2023. And so Kentucky chose to be a state to use an open model, which means we provide an EVV vendor, which our vendor is NetSmart, formerly known as TELUS. They had an acquisition since we have had them on board. So you'll hear both names, NetSmart and TELUS. Or providers can choose to have their own EVV vendor that they pay for, and they are just required to send the data to NetSmart as our aggregator, which allows us to do reporting and to have access to all the data. We currently have, see, I just did this the other day. I think it's 11 vendors outside of NetSmart. So we have about, and I think there was about 30 something to 40 something providers. I don't have the number off the top of my head that are using third-party vendors, but they're submitting the data to NetSmart. It's been, well, let me take a step back first before I go to that. So what it captures is it captures 6 critical data elements. So it captures who's receiving the service, who's providing the service, the name of the employee, when the service begins, when it ends, what the service is, and the location of the service. We've had kind of a rocky road with the implementation. And so while we went live January, we actually went live in November of 2020. We had required use in January, but we've been very lenient because we've had some roadblocks. We've had some speed bumps with the vendor in the system. We just recently issued the first threshold in that we expected providers by August 9th to have 50% of their visits that are verified in the system. And we had 44% of our providers hit that 50% threshold as of August 9th. And there's another 9% are close behind that. We currently right now are looking at those reports, and I'll be reaching out just to provide technical assistance to the other providers to find out, what barriers they're still encountering, what we can do to help. We have the next threshold is for the providers to get to 75% by November. But EVV, it's provided us with, sorry, there was a fly, has provided us with a lot of good data, looking at utilization and knowing when individuals have had visits scheduled and for whatever reason their employee didn't show up or they weren't able to get the services. So it's been able to give us a lot of good information to look at utilization and looking at when we've had people that unfortunately have taken advantage of our recipients and maybe have said they've been providing care, and we look and they were clocking in and they were 15 to 20 miles from the recipient's home, and it wasn't because they were picking up groceries for them. So it gives a lot of good information. We're also in the process of doing some modifications to the system to allow the individuals to have more access into the system and see, in particular, those that do participant directed services, since they are technically the employer, that would give them more of a view into the system. So it's moving forward. It has been a little bit rocky, but I was very happy with the reports as we started looking at them this week to see where we were at the percentage, at the thresholds. And I was very happy we have several providers that right now are close to the 100% or are at the 100% mark for compliance. So I'll pause there and see if there's any questions about that process or what our plans are going forward there.
Thanks, Pam. That was a really good overview. And I'm glad to hear that you've made some progress with compliance. Do people have any questions? One thing that I thought we might step back and do, the 1915 Sea Waiver programs, I think, are probably the most complicated. And if you could just provide, a very brief kind of description for our new members of what the waivers are and how they differ from
Okay.
regular Medicaid or traditional Medicaid.
So we have 6 waivers today. And so we have 2 waivers that serve individuals that have acquired brain injury. One is the acute and one is long-term care. And so the difference between the 2 of those is acute has a more intense level of service, and it's aimed at really rehabbing individuals and either getting them to the point that they're able to not be on the waiver, maybe still need some supports, whether it be natural supports or other Medicaid supports, but they're able to essentially graduate from the waiver or not need the waiver services anymore. The long-term waiver is for individuals that are going to need a more intensive level of support throughout the rest of their life. So they stay on longer on that long-term care waiver. Then we have the SCL and the Michelle P waiver. Both of those waivers serve individuals that have intellectual or developmental disabilities. SCL provides residential services, whereas Michelle P provides a lesser amount of services. It's capped at 40 hours a week, and there's not a residential component there. Sorry, Emily, thank you. I'm horrible about we talk in alphabet soup. And
Trying to translate. That's all right. I do it too.
And then our next waiver is HCB, which is confusing since all of them collectively are the home and community-based waivers, but we have one waiver that is called the HCB waiver, and it serves our aged individuals or individuals with physical disabilities. It is our largest waiver. And it also does not have a residential component. And then we have Model 2, which is our waiver that is for individuals that are ventilator dependent for 16 hours or more a day, or they are in an active weaning process. And it's our smallest waiver. We only have I think we're serving about 35 people right now. We stay between about 35 and 40 there. And so all of the waivers, the individuals have to meet the same level of care as you would for an individual that would be in a nursing facility. But with the services the waiver offers, they are able to remain in the community. And so, it's very important to us really as we look forward to aging in place and community integration and really person-centeredness to advance the waivers as much as we can to achieve those goals. We're serving about, I think I looked at our numbers recently, we're between 26 and 27,000 people right now that we're serving on all 6 of the waivers total.
Thanks. That's great to know. And there's also a waiting list of, I think, about 7,000.
We are actually at, I just did the numbers yesterday, we're about 7,500 on the Michelle P waiver right now. We are in the process of, we just allocated slots. It's been about 60 days ago. And we're getting ready to, our waiver year actually ends August 31st. So we will, as the people that have left the waiver and we have slots that come open, we will allocate again. So we're looking at probably within the next 2 months allocating another 200 to 250 people.
Right. All right. Thanks. So a question about the home and community-based waivers. We know that the American Rescue Plan Act, the most recent federal relief for the pandemic that was passed, that included some more funding for home and community-based services for the next year, or April through March of next year, I guess. Can you tell us what the high-level results are? I know Medicaid collected input from consumers, from waiver participants, from providers, and wondering what people were most interested in terms of, expanded or enhanced services and what the plan is right now.
So what we heard from on the participant and the advocate side, or the family member side, was around technology, more choice in services, more money to be able to pay PDS employees more service hours, and more providers to choose from. Those were the top 5 really consistent things from on the participant side. On the provider side, it was a lot around the loss of revenue, or dealing with the workforce shortage, waiver slots, trying to look at the expanding some of the services, maybe looking at services that we can't cover right now, or that are covered in a limited amount, being able to increase those services. PPE was also one that was mentioned by the providers. And I can send you, Emily, the link to our plan is out on the website now. So I can send a link to you after the meeting that you can send out, that and this is included in that what we submitted to CMS in our plan.
Okay, that's great. Yeah, it would be good to see for everyone. And what's the implementation timeline look like for this?
So we are waiting on CMS, along with almost every other state. I think I've heard of one state maybe that has received feedback. Our plan went in July 12th, so it's been just a little over 30 days. But as you can imagine, CMS received an influx of plans all at the exact same time. So they were committed to having turnaround as quick as they could, based on the fact that, we're limited on the amount of time that we have to spend the money. So right now we're kind of in a holding pattern for the feedback from CMS, but we're looking at things like, we're developing kind of a project timeline and project plan of, how to go, the steps to go forward, so that we're ready to go as soon as we get a green light from CMS, as well as we've been looking at a lot of data and a lot of reports. So we don't want to get too far ahead of ourselves in case CMS says, no, we don't like that. We want you to revise this part, but also not completely sitting back just waiting for them to give us feedback. There's a robust amount of reporting that has to be done to CMS every quarter. So one of the things when you see the plan is it's very high level, and that was done on purpose, because that allows us to adjust things as we move forward. And with each of those quarterly reports, it gets a little more defined, and we will provide more data back to CMS. But we're very hopeful to we'll hear something soon on our plan.
All right, thank you. Patty or Arthur, do you have questions about that, or any of our tech members?
I do have one. Can you go again? You said there were from listening to or hearing from consumers and what have you, there were top and providers, Pam, there were 5 top priorities.
So on the participant side, the top 5 priorities were technology, services to choose from, money to pay PDS employees, more service hours, and more providers to choose from.
What was the last one?
More providers to choose from.
More provider what?
To choose from.
More choice of providers.
More choice. Okay, gotcha. Okay, thank you.
Mm-hmm.
Any other questions? So the next question, it's one that was posed, I guess, to me at another meeting about Connect, our online marketplace, and plans to integrate the 1915 Sea Waiver applications. Arthur, are you asking a question? I think you might be on mute.
If he's on mute, or I think that we've lost him a couple times, so I think Arthur might be having some connection problems.
Arthur, if you can hear me, if you want to put something in the chat, or we can come back to you whenever we can hear you.
Yeah, he's not on mute.
Okay, there must be an audio issue.
Yeah.
If you look at the mute button, there's a little arrow that points up, and you click on it, and that can change your audio connection, if that's helpful at all. Or you can maybe try to call in. And Dr. Cantor, thank you for that additional information. So that question that I had gotten recently was about integrating applications on Connect so that people can apply through the same place you would apply for any other Medicaid coverage.
Well, I'm kind of confused because that integration is already there. I can send you some. So typically what happens is when somebody completes or begins their eligibility application for Medicaid, there are some gatepost questions that get asked. And if there's an answer of yes to any of those, I think there's either 5 or 7 gatepost questions, then it will send you to the waiver application. Or if someone is already Medicaid eligible, they can go out to Connect and can select to complete a waiver application, and it takes them directly to that. But I have I had the one of our technical staff with MWMA send me the quick reference guides. So I'll send that to you, and maybe you can pass that along, that has the instructions about how to do that and where to find that.
Okay, thanks, Pam. That would be
Okay.
helpful. And Charlotte, would you mind putting the phone number and password in the chat for Arthur?
Okay. Let me go
I
ahead.
was looking for it, but couldn't find it. So let's see. Pam, are there any other changes that are currently being made or are planned for the waivers that we should know?
Right now we still have the HCB waiver is still with take that back. It's with us. We got an RAI, which is the request for additional information. And we actually have a call with CMS tomorrow about that. But there's not, outside of that, we really there are several things within the plan for, within the ARPA plan that we really are wanting to look at as far as some feasibility studies. We know there are some changes that need to be made to the waivers. One thing is, the rate study. We are all committed to that starting, back up again, whether it's looking at the existing information or it be doing the waiver rate study from scratch. I think that part of what we're battling there, as I was looking at, because the waiver redesign task force, for any of you all that want to listen to that or like to or attend that, is Monday. And one of the things that we're talking about is rates and what we would like to see with redesign. But I think now it's a point that we're not only battling the fact that some of the waivers haven't seen an adjustment, we're battling against McDonald's, and we're battling against Target, and we're, the types of benefits that they can offer. And so I think that really we're going to have to look at it outside of just what are other states paying for these types of services? What does the, Bureau of Labor Statistics look like? But it's going to be what do we have to pay to get individuals to do these important jobs? And, when you look at, and not to make light of anybody working at Target or anybody that's working in fast food, but that job is significantly different than a job where you're responsible for another human, and you are, sometimes that other person is angry and has behavior issues, and you may get beat up, or that person you're having to lift someone, or it's very personal too, the kinds of the care that you're rendering. So when you look at the job that we're doing, and that was part of what we looked at with the ARPA funds, is how can we make first people understand what the direct support professional job is and the rewards that it has, and that it really is a career, and that it's not just I'm going to go, I think a lot of times it gets associated with the same thing as being a CNA at a nursing facility or hospital maybe. And it really is very different because of, what you're doing and to help people integrate into the community, and, really trying to help people to express their own goals and what they want to do. So really trying to change kind of the concept and the thoughts around what that job is. So I think that we know there are a lot of things that we need to do. Obviously, we want to address the waiting list, and it just is going to take the steps of getting there. But as of right now, we don't have anything. There's nothing planned. Most things that we want to do will take regulatory changes and waiver changes. And, you know, as I have been committed since I have started this job, there will be, you know, we will be very transparent, and we'll, you know, pick up those stakeholder engagement meetings and really involve everyone again in what we're doing. And because I think it's important to hear from the people that are getting the services, really to know what we need to do.
Thank you, Pam. I think Arthur, yeah, we can hear you,
I
Arthur.
hear him.
Freezing to where we can't hear nothing.
Oh, you can't hear us.
Yeah.
I'm sorry about that. Well,
You missed if Pam, the lady who was just talking, said anything about transportation. Did she say anything about transportation?
Pam, can you talk a little bit about transportation?
So right now, the only waiver that transportation is a service in is SCL, which we have, we actually were, ironic, Arthur, that you asked about this. We were talking about transportation earlier, and looking at that and looking at what are, in particular amongst the waiver participants, the transportation needs. So that is something I think that we want to address as well, is transportation.
All right, thank you. And Arthur, we may want to make that as a recommendation, which we can discuss more at the end of the agenda. Did you have any other questions for Pam about the waivers?
You have got you have got old and wore out. Talking about raising my pay. He said that he has got old and wore out about talking about raising my pay. Because people who pick up the garbage. People pick up garbage and make three times more than what we make. What did they say? What does that say about disabled people? It says we ain't what.
Did I hear you say that the payment rates are obviously very low, which I think we all agree with, too low, and it's been a real struggle and makes you feel like you're not important.
Well, and Arthur, I agree with you, and I would like with your permission, when I testify Monday with the waiver redesign, to be able to use your quote about the garbage about that, because I think that that is true. It says something when people, because I think this problem is become more than just about, I think when people were talking about rates, it was just about, okay, when have the rates been adjusted? But I think it's become much more than that. And so I would like to be able to use your quote when I testify Monday, because I agree with you. I think that makes a statement, and it doesn't make a very good one.
Email you about what? Her? Will you email him your email? And he will write out a little paragraph if you want to use it.
I will do that, Arthur. I have your email, so I'll send you an email when this is over. And respond back to me.
Thank you.
Thank you.
Pam, you brought up your testimony on Monday. Just so everyone knows, there are 2 special task forces that are meeting during this interim legislative period. And one is on the waivers generally, and a lot of the discussion is about the rates and the budget. And then the other is on severe or serious mental illness, and exploring whether we may have the opportunity to have a waiver for people with severe mental illness. And so maybe as the interim is getting closer to the end and there are recommendations, we could ask you to come and kind of speak to what those recommendations are, what's come out of both of those task forces.
I'll be happy. I have not participated in the SMI one as much, or the waiver redesign. I am usually on the agenda to speak for every session. So I'm happy to come and talk. Now we are as much a participant on that as we are any lead with that, but definitely I am not ashamed for, and anybody, if you go back and watch any of them, I think I've asked for money every time I testified. So and I do believe that, and I think the last time that I believe it was Senator Meredith said, it is obvious that we are going to that we need to give money to these important services. So I think that progress is being made, and I think that people are being heard. But I think Kelly also has put up, if anybody's interested, those also broadcast on YouTube and on KET. And I think that Kelly has up on our waiver pages, the link to that, or the time to that on Monday. If anybody is interested in watching those.
Pam, do you see Arthur's comment in the chat? I don't think you've addressed it. If you have, I'm sorry.
The transportation piece, yeah. So Arthur, I will add it to the agenda for our next meeting so that you can prepare and speak on that. And then Pam, looks like he needs a contact to speak to at DMS.
Yeah, I'm going to send him. So I'll send him my email address, and then transportation. If you want to, Emily, if you want to put it on the next agenda, and then I can get some report data together to be able to speak to that next time.
Thanks.
Mm-hmm.
Emily, this is Leslie. I participate in the SMI, just to let you know, so I can report back on that for you.
That would be great. Thank you, Leslie. We'll be sure to put that on an upcoming agenda, that both task forces, but we'll have transportation on the next agenda. So this is August, it'll be our October agenda. And I think just in light of time, we should probably move on to old business, but if there are any other items that we wanted to cover related to the waivers, we'll make sure to do that in October. So,
one question quickly.
yeah, of course, Patty.
Just real quick, on the waiver design task force, you said there were 2 of them. So, is that just that's just legislative task force, right?
It's a legislative task
It's
force.
just legislative. So there's actually no consumers.
No, they what they have done, just
So
out
what
of
is the
experience,
consumer input?
is they've had people testify, and I'm
Okay.
not sure how they're, like I said, we are a participant, so we, we get asked to come and to testify as well. So I'm not sure exactly how they are reaching out to the individuals that they have had to testify so far.
Okay, and also too, just one other quick question on transportation, Arthur. I mean, I think you just said that transportation on waiver services were just provided under SCL, but they're also under HCB too as well, right?
Well, it's incorporated into some of the services through HCB and as well through SCL and ABI, but SCL also has a separate transportation service. It's the only waiver that has that separate service, and it's a PDS service.
It's a PDS service.
The PDS that's specifically transportation, but you are right. It is transportation is incorporated in some of the other services.
Right, because it's in HCB, right?
It's in HCB as part of other services, as part of the attendant care service, they can do transportation.
So when we mention it, thank you so much, Arthur, because that's such a big issue. So yeah, you may want to look at like all of it.
He wants me to ask.
I'm sorry, could you get closer to the microphone again?
When? What date? Is she going to talk about your comment on the rate?
This coming Monday, Arthur, is that meeting?
In other words, you have 2 days to send some to you. He said, in other words, he has 2 days to send something to you, right?
If you can, yeah, it's Monday afternoon, Arthur. So as long as you get me something by Monday morning. So I'll send you an email as soon as this is over, okay?
Thank you.
This is Heidi. I just jumped right back in. Sorry. Arthur, are you guys talking about the waiver redesign task force meeting on Monday?
Yes, Heidi, he was going to give me some, I asked him for permission to use a quote that he said in this. Yes.
Gotcha. Because there are 3 other task force meetings going up through November on a Monday. So if for some reason y'all couldn't get it connected and all that, you could do it at a different meeting, was going to be my suggestion.
Yeah, absolutely. I'm more than happy that if I am scheduled to testify to take that. His statement was so impactful. I think that it deserves to be shared.
As is often the case with our statements.
Yeah,
absolutely. I agree. Yes.
All right. Well, I'm glad that opportunity exists. And I did put in links to both those task forces in case anybody wants more information. So in terms of old business, I just wanted to kind of quickly run through some of the items that we've asked or covered in other meetings. The first is about the preprint submitted to CMS, which is, the federal government, Centers for Medicaid and Medicare Services, for the hospital direct payment program. Just wondering if that's been approved, if there's something that we can see now, and when quality scores will be reported.
I'm afraid we still do not have the approval yet.
Still waiting. Okay, I'll just ask again at our next meeting. Thank you.
Okay.
or if you want to email me when you do get approved, if that's before October. And then the next item, Kentucky Equal Justice Center, actually Miranda, who's one of our TAC members, created a flyer to educate immigrants about emergency time limited Medicaid, which we discussed a little earlier in the meeting. KVH, that's Kentucky Voices for Health. We drafted a letter to providers about emergency Medicaid. We know that DMS has been reviewing it and wanted to know what the status is.
Absolutely. And my apologies for not responding back to let you all know that we reviewed it and we think that it's fabulous. And so we're excited to help use it and promote it and approve it. If you would like me to respond to the email officially, I'm happy to do that. But yes, thank you so much for putting that together. It looks great.
That's great to hear. And maybe we can talk, at another time about how to work together to promote it and get it in everyone's hands. Miranda, do you have any questions about that?
No, it's exciting. Thank you.
Yeah, good to hear.
Thank you.
In terms of our next item, the status of the 1115 waiver for substance use disorder treatment. 1115 waivers are basically proposals to CMS, again, federal government, saying, I want to demonstrate, kind of experiment with Medicaid coverage or how we are providing Medicaid services and do something a little different for 5 years to see if we can demonstrate that it works better than what we're doing now. And so this particular waiver that was submitted to CMS was to expand substance use disorder treatment for people who are incarcerated. Currently, Medicaid can't pay for any services when someone's incarcerated, and this would be asking the federal government to approve the Medicaid pay for these SUD services. So can we get a status on that?
It's
This is
still
Leslie.
pending. Oh, go ahead,
Sorry,
Leslie.
this is Leslie. It's still pending, Emily. I'm sorry. It's still been a very positive conversation. They said it's much larger than Kentucky now. Since we've submitted ours, other states have now tried to replicate what we're trying to do. So still positive, and I meet with them every month at the end of the month, and I'll give you a status update as soon as I have additional information. Thank you.
Thanks. That's good to hear, Leslie. And I'm not surprised that it's beyond Kentucky. I mean, I think that other states would find that to be a very valuable thing to do. I know that in Congress, there's been some interest in, making sure that people are enrolled in Medicaid before release. And that's something, of course, that we've talked about as part of this waiver, but also beyond just people who have an SED, just a substance use disorder. So very interested in, how we might be able to address that more permanently than just through a waiver. So something related, when people are incarcerated in jail or prison, their Medicaid is currently suspended if they were enrolled in Medicaid before incarceration. And what happens at times is when someone's released, their Medicaid is supposed to be reactivated, but it can sometimes go into this sort of like, I call it purgatory. Just basically it's still suspended and it can be hard for someone to get it reactivated, which is not the intent, but can just happen with the system as it is. So recently Medicaid put out a new form that someone could fill out once they're released to make sure that the state knows that I've been released, here are the dates, and that can be updated in the system so that their Medicaid is reactivated. And I'm just wondering how that form is working. If you've been receiving those, how are they being processed?
So we've received 45 forms to date, and processing time is around 2 days. Sometimes sooner, but generally not beyond 2 days.
Great. Have you noticed any issues with the forms that you're receiving, or do they have the information that you need?
A couple of them have required us to reach out, but really, I think it's going well. And yeah, it's not been overly time consuming for us. Right now, we were able to do it under current resources. I keep encouraging providers to send them in.
Yeah, that's great to hear. And I'm sure that providers probably could use a reminder that they even exist. I know I've talked in a number of meetings about the form, and often connectors too don't always know that it exists. So any education that we can do, maybe through the MAC, and other avenues I think would be helpful. Any questions about the things that I've covered so far? Additional questions? So the next one we have is the implementation of the single pharmacy benefit manager. That came up a little bit when we were talking about people who had recently had their presumptive eligibility coverage end and got this card in the mail, which was related to the rollout of the new single pharmacy benefit manager. We call it a PBM. So just wondering how that's going.
Sure. And I think Dr. Ali, she has to jump off at 3, but we're calling it a success. It doesn't mean that there weren't hiccups and some challenges. I have to give credit to MedImpact, which is our new pharmacy benefit manager for the managed care organizations. Just addressing issues very quickly as they came up. We all had the common goal of making sure the member got their prescriptions. And I think when we all work towards that goal, when it comes to access to care for the member, I think we come out with the right conclusion. So Dr. Lee, I don't know if you have other things you would like to share.
Yeah, Veronica, I think you hit the nail on the head there. I think overall it's been a success, and we're hearing a lot of positive feedback. We're also hearing constructive feedback, and we're working through that to ensure that we're serving the members to the best of our ability.
Thanks. I'm curious to know, I think if I remember correctly, that people whose medication is no longer, a preferred drug on the new single PBM, but were, already prescribed that drug before this transition, they have a 90-day period, right, in which that medication is grandfathered. Is that right?
Yeah, so the drugs that it applies to is the drugs that are not on the PDL. So those non-PDL drugs that at one point did not require prior authorization with the MCOs and now requires a prior authorization. Those drugs are grandfathered, but we are sending out lettering to prescribers and members, letting them know 60 days in advance and 30 days in advance that, that change will occur for them on September 29th. So we're taking all the measures in place to ensure that prescribers and members are informed and that they can get their prior authorizations in prior to September 29th so that there's no disruption in care.
Okay, so my next question may be a little bit premature then in terms of reporting any issues with filling those prescriptions or getting PAs approved. Is that, I suppose there are still prior authorizations for people who aren't grandfathered.
Right, yeah, so any new starts to therapy will still require prior authorization.
And have there been many issues there?
To my knowledge, no. I know that there have been a few hiccups in the way that the single PDL was being implemented on the MCO end and how it's being implemented with MedImpact. I do want to make it clear though that we went live with the single PDL on 1/1 of this year. There was a 90-day grandfathering window there, but after that, the Kentucky single PDL was to be followed after that.
By all of the MCOs. And now everyone, there's only one pharmacy benefit manager, whereas before July, every MCO had their own.
Yes, that's correct.
I'm just trying to get background for our new members. Okay, so in terms of like the constructive feedback that you've gotten, which I would assume is, the areas where we need to see some improvements, were there any like sort of things that came up more than once?
I think, in the beginning, we saw some issues around pharmacy reimbursement, but we were able to work through those. We saw a couple of things around members being locked into pharmacies, but we've been able to mitigate those as well and come up with solutions that are amenable to all. We're still working through a couple of things on the pharmacy end, but I think from a member perspective, we're starting to see some leveling off of,
calls to the Med Impact call center, the number of PAs being requested. So I think we're starting to stabilize as we go on.
Okay, that's good to know. Thanks. Does anyone have any questions about that pharmacy benefit manager transition before we move on? And then, Charlie, I guess you answered this question already. When will the recordings of our TAC and MAC meetings be available? It sounds like they're going to be on YouTube. Can you maybe
on YouTube? There's actually a link. If there is a TAC website that's the main one that lists every one of the TACs, and there's a link there to that YouTube page. There's also a link on the MAC website that is a list to the YouTube channel. And honestly, easiest way for me to find it is I just Google Department for Medicaid Services YouTube.
Okay.
Do it that way. So
all right.
What I go look for, that's what I look for, go do.
Thank you. So we'll make sure to get that link for everyone. I might try to find it while we're still meeting, but just wanted to stop again and see if people had any questions. Okay. Well, I think we can move on to our next item, which is making recommendations for the September MAC meeting. So the MAC is, the larger advisory body. We are one subcommittee. There are, I think, 19 separate subcommittees, which I didn't mention earlier. But you can find all of that information on the MAC page. Oh, thank you, Charlie, for putting that YouTube link in the chat. And I'll make sure everybody gets a link to the MAC page in case you want to go and look at that information. But what was I going to say? Oh, so with recommendations, we present those to the MAC, and the MAC can either choose to approve that recommendation, which means then, or not. If it's approved, then the Department for Medicaid Services is required to respond to the recommendation. They don't have to necessarily, adopt the recommendation, but has to at least respond. And at times in that we get a written response, at times the response will say, thank you for your feedback, and you don't get much more. Other times, there's kind of an explanation of why something can or can't work. And we have had many of our recommendations adopted. And I think that's really the value of having this consumer TAC, is that we can make recommendations about how to improve Medicaid for the people that Medicaid is meant to serve, which are Kentuckians who are enrolled in these various Medicaid programs. So that's the intent with our recommendations. And the only one that has come to my mind as we've been talking is related to the difference between presumptive eligibility and emergency time-limited Medicaid, and whether to clarify whether signing up for presumptive eligibility within 90 days of the onset of an emergency could satisfy that requirement for then enrolling in emergency time-limited Medicaid, which is a separate program. I know that's kind of complicated, but I am going to try to read the recommendation, and Miranda, since this is something you're most familiar with, you correct me if we need to do something to make it a little bit better. So my recommendation would be that DMS clarify the difference between presumptive eligibility and emergency time-limited Medicaid for providers. And I guess it doesn't necessarily need to be for providers. Should we say
this news came this
Medicaid members?
I think Medicaid members also need to know, but maybe include both, because I do think it's important to specifically.
Providers, I'll say providers, connectors, and Medicaid members, and separately clarify whether signing up for presumptive eligibility within 90 days of the onset of an emergency can satisfy the enrollment requirement for emergency time-limited Medicaid.
That's good, but while we were meeting, I looked it up, and actually the regulation and the DCBS manual both say 3 months rather than 90 days if we want to
3
use
months,
the same
thanks.
terminology.
That's good to know. Okay, so I'll just read this again. That DMS clarified the differences between presumptive eligibility and emergency time limited Medicaid for providers, Medicaid members, and connectors. And that DMS clarify whether signing up for presumptive eligibility within 3 months of the onset of an emergency can satisfy the enrollment requirement for emergency time limited Medicaid.
I think that's good.
Okay, so now what we'll do is vote. I'll ask everyone, I'll ask for a motion.
A motion.
Thank you, Miranda. And a second.
I second it.
Thanks, Christine. All in favor, say aye.
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 Any opposed? Okay, the motion carries. Are there other recommendations that TAC members want to make?
I just wanted to see, did we skip over an agenda item on MCO vaccination rates?
Oh, we did. I'm sorry. I don't know how I did that. So let's go back. Thank you, Miranda. So under new business, we had some questions about vaccination rates. Some people may have seen that there was an article recently that showed that the vaccination rate of Medicaid members was about 25%. I don't know how that, kind of differs depending on geography, age, and other, factors like race and ethnicity. That's one question, if there are demographic differences that could be shared. And then the other question is, what outreach is being done to Medicaid households to increase those vaccination rates? And what I was just sharing was COVID-19 specifically, but we know that childhood vaccinations have also decreased because, fewer kids were going to their wellness checks since the pandemic started. And I think a lot of the sort of vaccine hesitancy and the anti-vax messages that have been really focused on COVID-19 have kind of bled over into immunizations generally, which is a real concern. So anything that DMS or MCOs want to share there?
Emily, this is Dr. Kanner. I'm the Interim Chief Medical Officer at United Healthcare. I'm happy to talk on both of those points if this is okay with you.
Yeah, thank you.
Great. Regarding the childhood immunizations, that is a very true statement. Our concern is there with you as well, that last year in 2020, we do know that there were decreased immunizations. However, we are a new MCO to Kentucky as of 1/1 this year, so we don't have data specifically around HEDIS. However, our outreach initiatives are multifaceted. We do member website education on the importance of vaccinations. We have a quarterly newsletter that just went out this summer. We also have specific mailing educational postcards to members who miss the vaccination doses at 6 months, 8 months, and 16 months of age. There's also, following that mailing, we have an educational phone call that goes to that member or the parent or guardian. Then we also meet with the PCPs through our provider quality engagement consultants to be able to share specific patient gaps or care opportunities to be able to close that gap in care around childhood immunizations. And regarding our COVID-19 vaccination strategy, I know which article you're referring to that talked about the decreased rates for the Medicaid population. I'd like to point out that we get information from DMS weekly, and United Healthcare has most recent weekly update shows that we are at 30.37% for those members who have had at least one COVID vaccination. And our approach for several months now has also been multifaceted. We have worked with our providers. We're doing direct member engagement, various data and training outreach efforts, many community outreach places throughout the state we're doing, as well as we have incentives. Specific incentive is a $100 gift card incentive to Walmart or CVS after an attestation is received that the member has received those 2 doses of a 2-dose vaccine or the 1 dose of J&J. We're also able to give 14 home delivered meals as an incentive to those to encourage our members to receive the vaccine. To get a little bit more in detail about that multifaceted approach regarding providers, we've targeted and specific PCPs, FQHCs around the state to listen and learn. We're sponsoring various incentive raffles with FQHCs, TVs, large screen TVs type of thing. Last week, we had a provider town hall with DPH for all of PCPs in Kentucky. We were able to offer CMEs for that, as well as we've offered and provided PPE donations. In terms of direct member engagement, we have sent letters, we make phone calls, we do an automated type of call for missed second dose. And then at all of our member open houses, we talk about the opportunities and the benefits of the vaccination. With community outreach, we are doing some really interesting work. We've been able to work with Kentucky youth advocates, and they are doing some focus group work right now this month of August, and some fascinating takeaways are coming in. One that comes right to my mind is that the particular youth that were talked to said, we would like to be able to hear from celebrities and other influencers, but really not the government. So just wanted to share that, lift that up right away to this group, that who our young people are listening to and who they believe are their influencers. We also sponsor flu vaccine clinics. We are working with Walgreens on that. We have a variety of educational center sessions within international centers. We have a mobile vaccine clinic at Lexington Legends. We had a session out at a community event with Lynn Bowden, and some members showed up and said, well, if he got it, then I'm gonna get it. Again, that celebrity came right out, and that was the influence that got someone vaccinated. We also have our QMAC, and we discussed various vaccine points at that meeting. We're now working on upcoming faith-based organization outreach and fall festivals. And with that, thank you so much for letting me share that data. Thanks.
Thanks, Dr.
This is Tabitha with WellCare. I can also share just some of the highlights that we're doing as well, and I can drop these in the chat for you so you can have.
Yeah, that would be great. I think you're back on mute, Tabitha. I don't know if you meant to do that.
I'm so sorry. I didn't even realize that. My apologies. Some of the outreach campaigns that we have is doing some in-home vaccination programs. So we're helping with our members in the rural communities. We've started across all 8 of our regions for that, at least 2 counties in each region, and we'll be expanding. We have the vaccine incentive as well for $100 gift cards. We're doing Shot Across the Bluegrass, where we're going into the rural counties with live KSR broadcast. So inviting our members in for those, doing vaccine clinics and back to school events for the underserved and refugee communities. Our teams are actually have outreached 95,000 members that were at risk to encourage the vaccine and help them to get those appointments where necessary. Doing KAHP state fair incentives. We've had 750 plus volunteer hours at vaccine sites in homeless shelters, domestic abuse victims, faith-based and African-American communities. Also kind of following along with connecting like the celebrities with our Pro Football Hall of Famers and other athletes to increase that education and awareness about the vaccines through public service announcements with a particular focus on communities of color. And we're doing some festivals across the state in the next coming months as well. They're similar to healthcare, health fair initiatives, but we're focusing on vaccine, dental, and just wellness events across the state. And also doing the American Heart Association radio series in English and Spanish. for the months of October and November through November. So that's WellCare outreaches at this time.
Great, thank you.
I can speak for Anthem. My name is Victoria Jude. I'm the community outreach manager. And so far, member vaccination, fully vaccinated, we have 29,426 and 4,571 that have received the single dose. So about a 26.4% for our membership. As far as age groups go, we have about 1.2% that are under between ages 12 and 15, and about 1.8% that are between ages of 16 and 17. And then 19.7% of 18 to 29, and 20.3% that are between the ages of 30 to 39. 18.3% that are between the ages of 40 to 49, 33.1% that fall between the ages of 50 to 64, and 5.7% that is 65 and plus. As far as the individual options for the vaccines, we have about 48% that are Pfizer, 45% that are Moderna, and then 7% that are J&J. And we have been, as far as our outreach efforts, we do promotion through our social media, postcards with the QR codes, text messages, emails. We have done outreach and informed the members of the one-time $100 healthy rewards by logging into their Benefit Reward Hub account and reporting their vaccine info. So far, we have 1,119 members who have reported receiving the vaccines and actually have entered the information and redeemed this $100 reward. We also, as far as our outreach efforts, we did go into the top 8 lowest vaccination counties across Kentucky and did vaccination clinics. And that included Trimble, McLean, McCreary, Christian, Elliott, Crittenden, Jackson, and Union counties. And then we also launched a back to school initiative to do go into partner with our local schools and health departments and stuff to do back to school events where they held the vaccination clinics as well.
Thanks, Victoria. This is all really helpful information to have. Dr. Beal, did you want to share?
Sure, I can speak for Passport. I'll echo the $100 incentive that the other MCOs are mentioning. We're doing the same thing, of course, trying to get those last folks vaccinated. I'll speak to COVID first, and then we'll switch over to pediatrics a little bit. Our numbers look kind of similar to the other MCOs. We've got it as of the last reporting from DMS's data. We had 34.94% of our population that's vaccine eligible vaccinated, with those numbers decreasing as we get to our younger members naturally, because our older members were able to get those vaccinations first and earlier. So we're continuing to push kind of hard, especially at some of our back to school events for our younger members to get vaccinated right now. And we're partnering specifically with JCPS to help provide some folks to any of their outreach efforts to do vaccinations at larger JCPS events. Since Region 3, we have such a dominant population in the public school system. I can add that we have, in June, we started an intensive calling campaign to all members that hadn't been vaccinated yet. We called, I think we called over 15,000 members between June and July, just from one set of our organization making those outreach calls. And then in July, we switched over and we're doing very targeted outreach calls to the remaining members, starting with Region 3 and then moving to the other regions. We actually started with our regions that had the lowest vaccination rates, and then we've bumped it over to Region 3 calls, and we expect to have all of those outreach calls completed in the next, I believe, 6 weeks. So that's kind of what we've been doing. And then of course, information going out to members through text and other campaigns, auto dialer campaigns, et cetera. We've sent over 177,000 text or auto dialer messages to our members, trying to get them excited about getting vaccinated and also let them know about our incentive. You had asked around some differences for racial groups, et cetera. I can report to you that we definitely are seeing a difference between our populations, and the majority of our members that have been vaccinated are white or Caucasian. So about 20% of those members, 6% are African American or Black, and 1% identify as Asian. So we are seeing some discrepancies there for sure. We're also seeing a difference between our male and female membership, where the majority of our members that are vaccinated are female, and the minority are male. So hopefully that helps you as you're starting to think through how you're working as well. As far as childhood immunizations, since I am the program director and manage all things EPSTT, those are very close to my heart. And we likewise saw rates fall last year. We don't have great data right now on our current HEDIS measures for that, but our metrics last year ranged from 35 to 73%, depending on which vaccinations we were looking at, fairly commensurate with what we see across the Commonwealth as a whole, with things like combo 10 being harder to achieve. And those types of things. We have started some new types of outreach efforts for our kiddos this year. So one of the things we're doing is that we are mailing birthday cards to our members the month prior to their birthday, hoping that it arrives right around the first of their birthday month, reminding them that it's a great chance to get their well child check if they haven't gotten that already. And we have targeted information in those about vaccinations. We're also doing care gap calls. So similar to what you heard from the other MCOs, when we realize that somebody has passed a milestone that we would expect them to have claims for a well child check and they haven't, we're outreaching those members by phone and helping them schedule those well child checks to help push, and discussing immunizations when we're on the call with them as well, reminding them of the vaccination schedule and what their child might be due for. And then we have additional care gaps that we're providing to our providers so that they know which members we serve, that they serve as well, that may be missing immunizations and other needs. And we've got some targeted information going out in Q4, specifically around immunizations, to some of our providers to try to encourage more of our providers to do them in-house. We found that we have some providers not doing them in-house, and we're realizing that's causing some problems and challenges for our members in terms of continuity of care and ease of access. And then we've got some tip sheets posted on our provider portal for providers as well, just to make sure that we're capturing codes correctly so that we're really seeing what our immunizations rates are accurately. And then of course there's incentives for our members for our 1 to 3 year olds, where we have some heavy immunizations happening around going to those well child checks with $10 per visit of a maximum of $60. So that's kind of all the updates I have at the moment. If you have any questions, let me know. You're welcome.
I think that we're going to get an email update from Aetna. So I'll make sure that all of our consumer TAC members get that email update. Is there anyone else who wanted to share?
This is Khaki Stevens with Humana Healthy Horizons. I sent some slides over earlier this morning to Angie Parker and Charlie with this information as well in more detail, so you guys can review those and ask any questions. But we're doing some similar things as the other MCOs have reported. We're doing a lot of member outreach. We're doing second dose reminders, coordinating transportation when needed. We're doing the broad-based call outreach. And we have a text campaign upcoming as well. We're also performing a vaccine hesitancy study that's in progress, so more to come there. We're sharing the vaccination analytics with our providers to support their direct outreach to their patients. And then also offering provider vaccination reimbursement and for our members, vaccination healthy rewards incentives, along with supporting some of the sites, the vaccine sites across the state. One in particular was the West Louisville site, where nearly 3,000 vaccines were administered at that site. And then we will be participating in the Kentucky Association Health Plans collaboration at the State Fair in giving vaccines there. And of course, there's incentives involved in that as well. The slide, we're kind of close to what I believe Wellcare said earlier, United, forgive me, I've lost track here. But we're a little over 30% as far as the total percentage for vaccinations. And that breakdown is on the slides provided as far as the ages, with the higher vaccination rates being 40 and over, and especially 60 and over, they're at 55%. And then, of course, as you go down to the lower age groups, the percentages decrease. And we broke it down by region as well for you. As far as our other immunizations, childhood immunizations, I included a slide for that as well. And I'm so sorry, my dog is crying in the background. She wants to get a squirrel that's in the front yard. So the childhood immunizations, we're seeing the same thing as mentioned with some of the other MCOs. Last year, we saw a decrease in the vaccination rates, but we are already have double this year what we did for the whole time last year. So that is included for you as well. And I will let you look at the slides that we provided this morning. And if you have any questions, please send them our way and we'll be happy to answer them.
Okay, thanks. That's really helpful. And yeah, all of the information that we're getting in the chat too, I think can be, incorporated into the minutes. Hopefully it can. So this has all been really helpful. Is there anyone else? Catherine, did you want to share for Aetna?
Yeah, sorry. So I know we're almost at time, so I'll keep it short. But Aetna, starting with COVID, has been doing the $100 gift cards and $25 gift cards for 12 to 15-year-olds. We're seeing great uptake, especially recently with Delta, I think spurring some sort of the incentive, since we've been doing the incentive since late May. So I think that has helped get word of mouth out there. We've been doing vaccine clinics all across the state. We've had unusual success with them. The public health departments tell us not to do them, and then we end up getting about 35 members or 60 people total. So we're excited about those. And I will email this over too. But we have, among our members who are vaccinated for COVID, it aligns with our demographics of our population. We've got about 77% who are Caucasian and 8% of African Americans, which is in line with our 80% of Caucasian membership and 11% African American. Our SKY participant rate for COVID vaccination is higher than the general Medicaid population ages, which I think is also helpful that they are in a program that has a lot of case management touches that's helping improve those rates. And other highlights, let's see. We have over 30% in region 3 with vaccine eligible members with at least 1 dose. So we're excited about that. And our other highest regions with our highest vaccination rates are 3 and 5, seeing the most challenges in 4 and 2. And then as far as childhood, we have a lot going on there. We've been doing texts, we've been doing high touch case management, member outreach. We've been doing mailers. We've sent about 80,000 mailers this year so far. And I think as Kathy mentioned, the birthday mailers, that's the same thing. We send the month of their birthday to make sure that they get reminded of those immunizations that are due. And I will stop there, but I'm open to any questions and I'll make sure to send this over.
Thank you, Catherine. Yeah, to all of our MCOs, if you would like to just send any of your notes, reports to Charlie, we can incorporate all of that into one place. That would be really helpful. And I'll just say, with Kentucky Voices for Health, we often get some of these flyers about incentives and events, which is really great to see, but I don't know how much it's getting to consumers. And a request that I will just make to y'all is, if you could, as much as possible, put that on social media as something that can be shared. I just think we could get it out to a lot more people that way. And it would be easier for providers too, I think, to share those social media messages and get it out to more folks. Since we're so remote now, flyers just don't work the same way that they used to. So I know we're, at time. If we have more discussion about immunizations or questions, we can cover those at our next meeting. I do want to just respect everyone's time and get back to, the last couple items on our agenda. Arthur, did you have a question?
May I ask something?
Yeah. Yeah, please do.
He did it again. Can you hear him?
I can hear you. You're a little quiet, but if you just move a little closer, I think that'll work.
No. He doesn't know much about technology. He wants to know if there is any way he can record this and save it on his computer.
The recording for this particular recording? Is that what you're asking about?
This meeting, like he's asking if there is a way that, well, is the meeting recording, if it's a way he could save it to his computer?
Well, it's going to be available on YouTube and you could probably download it from there. So Charlie put the link in the chat and we'll make sure that it goes out in an email to you too, Arthur.
Okay.
So yeah, I think it's fantastic that we have these recordings now. And just wanted to make sure our new TAC members and of course everyone knows that our next meeting, we meet on the third Tuesdays of the month, typically at 1:30. Our next meeting is October 19th. The last one that we have for the calendar year is December 14th. And then our next MAC meeting where we'll make the recommendation that we've already voted on, that's going to be at 10 o'clock on September 23rd. And I do a report at that meeting and I'll share that report with you before I actually present it to the MAC. And I will put forward the recommendation there and then the MAC will vote on it and I'll make sure everyone has an update. Arthur, did you have something else you wanted to say?
He said no.
Okay. The other thing that I'll do is in advance of our next meeting, I'm going to send out a draft agenda. I usually get things started based on what our old business is and anything that I've heard from folks. And then you can add new items to the agenda. I'll make sure transportation is on there since we discussed that today. And if y'all have questions or want to just talk and get a little bit more background on any of the things we discussed today, I'm happy to set up a call between this meeting and the next one. But I really appreciate everyone's time. Thanks to all of our MCOs for being prepared to share such comprehensive information about vaccines and the outreach that you're doing. And I will see everyone in a couple of months on October 19th. Thanks. Oh, I guess we have to officially adjourn the meeting. I'm sorry. Can I get a motion to adjourn?
A motion.
Thank you, Miranda. A second?
Aye.
Thank you, Arthur. All in favor?
Aye.
Aye. Any opposed? All right. We are officially adjourned. Thanks again, everyone. Have a good afternoon.
Thank you all.